The video you're about to watch is from a talk that I gave at the Southwest College of Naturopathic Medicine in Tempe, Arizona. I go over the history of ketamine, I go over the research, I go over some of the side effects and contraindications, a lot of information. So definitely check it out. There will be a link to the slides, there will be a link to the citations, so check that out in the description, and please enjoy the video. And with that, I want to start my presentation. So it's titled Ketamine, A New Way to Change Your Mind. I also put up all of the slides and the references on resetketamine.com/AZ Psychedelics. So that'll be the PDF of the PowerPoint and the reference. A couple of disclosures. I am the founder and medical director of Reset Ketamine. This is a discussion of ketamine in the quote off-label use for mood disorders. And our objectives for today, we're going to talk about the current state of mental health. We're going to discuss the history of ketamine. We're going to review the evidence for ketamine, specifically in depression, suicidal ideation, anxiety, PTSD. We're going to discuss mechanisms of action of ketamine, some side effects, contraindications, the biopsychosocial spiritual model, and then if we have time, we'll get to some case reports of patients. So modern medicine is phenomenal. If you are in a severe car accident, if you're having a heart attack, if you have an acute appendicitis, go straight to the hospital. Don't mess around. But there are some things that we can truly improve upon in medicine. And that one area I would say is mental health. So 1 in 4 adults suffer from mental illness. Very likely someone you know. If it's not you, then it's someone you know who's suffering from this, and they may not be talking about it. Depression. According to the World Health Organization, depression has now surpassed HIV, AIDS, malaria, diabetes, and war as the leading cause of disability. 16.2 million Americans have experienced a major depressive episode, and depression is much more common in females than males. Some studies report up to 20% of teenagers experiencing depression before they reach adulthood, and statistics are showing that it's actually increasing, the prevalence both in teenagers and adults. Now, the thing with depression is it can lead to suicide. Close to 800,000 people commit suicide every year. And according to the CDC, the national suicide rate has increased 33% between 1999 and 2017. Suicide is now the leading cause of death for Americans from the age of 10 to 34 years. And believe it or not, there's twice as many suicides in the United States as there are homicides. Anxiety is something that's super common, with an estimated 31% of Americans experiencing an anxiety disorder sometime in their life. Nearly 2/3 of Americans are extremely anxious or somewhat anxious about health and safety for themselves or their family. And also anxiety, the prevalence is increasing. Moving on to PTSD, an estimated 3.6% of US adults have had PTSD, and it's not actually just veterans. The rate of PTSD is higher in females, about 5.2%, versus males, 1.8%. And that actually stems from a lot of interpersonal violence. The overall lifetime prevalence of PTSD is at 6.8%. So what are some of the treatments? Mainly, one of them that I want to touch upon is selective serotonin reuptake inhibitors, antidepressants. They're effective in about 1/3 of patients. They take weeks to months to kick in, and they have a host of side effects: loss of libido, weight gain, insomnia, anorgasmia, and suicidality. And recent studies are showing that those who take SSRIs have a 33% higher mortality rate than those who don't. So what if serotonin is only one part of this depression, anxiety, PTSD story? And what about other neurotransmitters that are within the human brain? And what are some other treatment options that we can offer to patients? And there I want to talk about ketamine. So ketamine is a member of the arocyclohexylamine group, but, and there's multiple structures here. The first one I want to talk about, which is the grandfather of ketamine, is phencyclidine. So phencyclidine, also known as PCP, was invented in 1926. It was patented in 1965 by the Park Davis Pharmaceutical Company for use as a general anesthetic. But it had terrible side effects. So the person would undergo general anesthesia, and then they would have these bizarre psychotic symptoms lasting hours after the procedure was complete. So they actually voluntarily withdrew this drug, and but unfortunately some street chemists took this drug and made it a drug of abuse, and it became super popular on the streets, known as angel dust and PCP. But going back to ketamine, so Park Davis Pharmaceutical Company, they had this drug, bencyclidine, which was a pretty solid general anesthetic. They requested an organic chemist, Dr. Calvin Stevens, and they said, hey, we have this drug. Can you take this drug and make derivatives that will have a lower side effect profile? And he made multiple derivatives of this. One of them was called CI-581, and which was later renamed ketamine. And it's called ketamine because of the amine group and the ketone group in the chemical structure, which is here. Ketamine is the bottom right, and the little dolphin. So you have the ketone and the amine group. In 1964, a psychiatrist, Dr. Edward Domino, used ketamine. He took 20 volunteers from Jackson Prison. I don't know if they were fully volunteering, but he took 20 inmates, and he gave them progressively increasing doses of ketamine. And what they described was feeling spaced out, floating at the lower doses. And then they gave them progressively increasing higher doses. And what they found was that at the higher doses, the ketamine induced a profound anesthesia. And what was key was after the ketamine had stopped, they would rapidly recover and come back to a normal mental state. So this was in the 1960s when ketamine was invented. And some of you may know this was when there was the Vietnam War going on. There was LSD, Timothy Leary, Nixon, turn on, tune in, drop out. But Park Davis Pharmaceutical Company wanted to get this bypassed through the FDA. But because there was this social stigma around these drugs, schizophrenia-mimetics like LSD, they wanted to come up with a new word, a new way to describe it. So Dr. Domino's wife came up with this term called dissociative anesthetic. And the reason it's called dissociative anesthetic is because it dissociates the mind from the body. So they got it approved. Boom, 1970. FDA approved it for use specifically as an anesthetic for children, adults, elderly, during surgical and diagnostic procedures. And it is still FDA approved for this indication. So 1970, Park Davis got the approval, they patented it, and then this was actually the most commonly used battlefield anesthetic, sedative, and analgesic agent during the Vietnam War. And it was great because these combat soldiers could give a shot of ketamine to a wounded soldier and then get them back to the medical tent because it didn't have as much sedating effects as morphine or another opioid derivative. 20 years goes by, from 1970 to 1990. It's used extensively in anesthesia in the operating room. Then in 1990, this landmark article comes out saying ketamine is safe in use as a procedural sedation agent in the emergency room. And so from 1990 on, it was used by emergency physicians for anyone who is undergoing a painful procedure. Ketamine has been used for over 50 years. It's on the World Health Organization list of essential medicines, and those are the medicines that are the most effective and safe that is absolutely needed in a healthcare system. So I want to talk about some of the research behind this. So let's talk about depression and the first study that was done. So this article was published in the Society of Biological Psychiatry in 2000 by Dr. Berman. They took 7 subjects with major depression, and this is a placebo-controlled, double-blinded study, meaning that there's the inert substance, plus both the receiver of the drug and the researcher does not know what they're receiving. And what they found, if you look at the data here, the white circles are the placebo and the black circles are the ketamine. And on the y-axis, you have the change in the depression score. So there was a significant drop in patients' depression scores using ketamine, and what they received was 0.5 milligram per kilogram IV infusion over a 40-minute period, and they received 2 treatments in this study. Now, since the year 2000, multiple scientific trials have been performed, and meta-analyses, which are reports that take multiple randomized controlled trials, bring them, kind of summarize them, have showed that ketamine is rapidly effective in treating treatment-resistant depression. But the limitation is there are no long-term studies on it. Someone has depression that can lead to suicide. Can we use ketamine for suicide? This study was published in the American Journal of Psychiatry in 2017. They took 54 patients. They were voluntary inpatients at a psychiatric unit. They were double-blinded with an active placebo. So instead of saline this time, they used another substance called midazolam, which is a benzodiazepine. So it'll make the patient feel something. And they gave them 0.5 milligrams per kilogram of IV ketamine versus 0.02 milligram per kilogram of midazolam over 40 minutes. And then they measured their scale for suicidal ideation. And then the patients who received the placebo, if they didn't get a response, then they offered them ketamine. And if you look at this graph here, you have the red, which is the response from ketamine, the drop in the suicidal ideation. The green was the active placebo. And then the orange line represents the patients who were in the placebo group. And then you switch them over to the ketamine group. And again, there is a significant drop in suicidal thoughts after receiving intravenous ketamine. So this might be a future option for patients who go to the emergency room, who go to psychiatric hospitals. But someone earlier had asked, are they using this now? No, they're not. It is definitely out of the box thinking. It is very unusual. It would be outside of the standard of care to do it. However, they are doing research at Columbia University, seeing whether ketamine can be effective. And I think one of the questions they have about this is someone just might be like, hey, I'm suicidal, I need ketamine, and there might be some conflicts of interest there. But according to this article, the VA, the Veterans Affairs, is actually considering and using ketamine, at least at one site. This is at Lewis Stokes Cleveland VA Medical Center in Ohio, and they are beginning to use ketamine at this one hospital. So let's talk about anxiety. This study was published recently, also in 2017, in the Journal of Psychopharmacology. They took 12 patients. They were all treatment resistant. They either had generalized anxiety disorder, social anxiety disorder, panic disorder. They had tried antidepressant, psychotherapy, etc. And they gave them varying doses of ketamine, either 0.2, 0.5, or 1 milligram per kilogram. Out of those 12 patients, they found that 10 people reported a 50% reduction in the Hamilton A score, or the FQ questionnaire, which is the fear questionnaire. And they found that there was a significant drop, in particular when they received the higher doses, the 0.5 milligram or the 1 milligram per kilogram dose. So looking at PTSD, this study was done. It's the efficacy of intravenous ketamine for the treatment of chronic PTSD. Again, a randomized clinical trial published in JAMA Psychiatry in 2014. They took 41 patients. This was a proof of concept study, so it was a single infusion using ketamine versus midazolam. And again, if you look here, you have black, which in the triangle line, which represents the midazolam, the placebo, versus the blue or the square line, and that represents ketamine. And after one infusion, there was a significant difference comparing ketamine to midazolam in the scores of PTSD. So this is fascinating. How does ketamine work? So ketamine blocks one of the neurotransmitters. I mentioned serotonin earlier. It blocks the activity of glutamate. It is known as an NMDA receptor antagonist or blocker, where the glutamate is supposed to bind. Ketamine will come in and prevent the glutamate from binding. And that is the proposed mechanism of how ketamine is creating these pain-relieving effects. But ketamine isn't particularly very specific to one receptor. It has effects on the mu, kappa, deltoid, opioid receptors. It has effects on the dopamine D2 receptors. It has effects on the serotonin, acetylcholine, GABA, cannabinoids, nitric oxide, and sigma receptors. So it's working on a multitude of sites. This is a kind of a complex graph But this is what's happening, the proposed mechanism of what's happening on the synaptic level. It increases brain-derived neurotrophic factor, BDNF. It increases protein synthesis. It increases the connections between synapses in the neurons, as well as synaptogenesis. This is a diagram showing what happens after ketamine in the rat model. And on the top, A and B, you have dendrites, neurons, and B is the close-up of the neuron. And then 24 hours later, you have C and D, and D is the close-up. So bottom line, what you're seeing is that ketamine reverses these chronic stress-induced structural deficits that decrease the connections between the neurons. So one of the metaphors that I like to think of is like a tree, and so you can have like a tree with its leaves all withered and brown, but ketamine seems to go in there, almost act as a fertilizer to increase the strength of that tree or the branch. Another thing to consider is the default mode network hypothesis. There are certain portions of your brain that are active when you're doing nothing, when you're daydreaming, when you're resting, you're not engaged in a task. And that's known as the default mode network. So the default mode network, they believe it plays a role in depression, PTSD, schizophrenia, autism, and chronic pain. The default mode network one example would be like if someone has this chronic self-defeating story of like, hey, I'm not good enough, or everyone hates me. It's just this chronic habitual way of thinking. And what ketamine does is it seems to temporarily disrupt that activity of the default mode network. And that can allow the brain to come up with other alternative habits or activities instead of that default mode. The other experience specifically for the patient is the non-ordinary states of consciousness. So patients might have this empathogenic experience where they're aware of the body, they're comfortable, there's reduced ego defenses. They might have an out-of-body experience where they visit mythological realms of consciousness. They might have dreams about spirits or deceased relatives. And if you go at a higher dose, they're going to have a near-death experience where there's complete ego dissolution, loss of identity. They might experience a physical or psychological death in their mind. And then finally, the ego-dissolving transcendental experience, where it's just complete dissolution of the body and soul, where they feel this unity with nature, universe, sacredness, ineffability. But there are some side effects and contraindications. You don't want to give it to everyone. Earlier, we had spoken about this emergence phenomena that you had seen in PCP. That can happen actually in about 10 to 20% of patients after ketamine for PRS, which stands for procedural-related sedation. There's something dangerous called laryngospasm that can happen, where your vocal cords will actually shut tight and not open. And that's important because if that happens, you're not going to breathe. People will be agitated, nausea, vomiting, super common. There's going to be elevated blood pressure, heart rate, and so we always want to monitor their blood pressure and heart rate as they're receiving the ketamine infusion. And then lastly, I put the side effect, hallucinations, mystical and spiritual experiences. Some people may not consider that a side effect. And then the other thing, people, you probably have heard of ketamine. It's known as Special K, Kit Kat, Vitamin K, Super Acid, Cat Valium. So there is abuse going on. That's the truth of it. And a recent study from 2011, they interviewed high school students looking at 8th graders, 10th graders, and 12th graders, and they found that 1.7% of 12th graders had tried ketamine once, 1.2% of 10th graders had tried it once, and 0.8% of 8th graders had tried ketamine. So it is there. It's rare compared to other drugs, but it is there. And then lastly, another study that looked at specifically in the United States, they found that as far as the general population, 0.1% of the population has tried ketamine once in their life or multiple times. So the important part of this is, it's a drug, and some people can abuse it. So we have to discuss the set and setting, and I'm sure who does not know what set and setting refers to? Who does not know? Okay, so everyone, who does know what set and setting is? Okay, great, I'm in the right conference. I'm gonna skip that part. Okay, let's talk about, dependence again. If you look at this graph, on the y-axis you have the dependence potential, meaning how addictive it is. On the x-axis you have the active dose over the lethal dose. This is from Wikipedia, so you can just find this pretty readily. And at the far right you have heroin, which is very addictive and the active dose over lethal dose, very high. So that's one of the more dangerous ones. And then on the very bottom, you have the LSD psilocybin, which has a very low rate of dependence, and it's not as dangerous. And then kind of somewhere more on the lower, you have ketamine here, which has a lower dependence potential. It is there, but it's low. And then as far as the active dose over lethal dose, it's not 100% safe. You need to be monitored. You need to be observed while you're receiving this because high rates of it can cause problems and high doses. So patients who shouldn't receive ketamine, if they have uncontrolled high blood pressure, if they have unstable heart disease, if they have untreated thyroid disease, if there's active substance abuse, active manic phase of bipolar, active delusions, hallucinations, if there's a history of schizophrenia or family history of schizophrenia, or any prior adverse reaction to ketamine. So we screen for all of this prior to giving any ketamine infusions. So at Reset Ketamine, we just opened this up April 2018 in Palm Springs, and I wanted to share with you about our approach. If you look at the definition of health from the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I really like that. And I use something called the Biopsychosocial spiritual model. I went to University of Rochester where the Biopsychosocial model was founded by Dr. Engel. I added the spiritual, and I guess I attribute that to my training at Loma Linda University, which is a religious institution. If someone has a disease process, you can't just look at the biology. Biology is important. You've got to look at the particles, molecules, DNA, epigenetics, the cells, tissues, organ systems. Do not ignore that. But you have to also consider the psychology, the mind, the unconscious mind, the conscious mind, life experiences, their behavior. You have to consider the social component, the relationship with self, partner, friends, family, community, society, earth, galaxy, universe. And then the spiritual component of disease. And this is kind of general because it's hard to define what spiritual is, but I would say anything that transcends the normal human body. So the reason the biopsychosocial spiritual model is important is because we label biology is here, psychology is here, sociology is here, spirituality is here. And this map on your left shows Arizona, and you have California, and there's like this thick red border around the state of Arizona. You're looking at it and there's obviously, this is where Arizona ends and this is where California begins. But when we were driving from California to Arizona, I didn't see that red border. I saw a little sign that said Arizona Centennial. The reason I bring this up is there really is no connection, there really is no boundary between biology, psychology, sociology, spirituality. It is all connected. They're in different areas, but to place an artificial line, which we do all the time, may not support the patient at its best. And yesterday, I was working out with my wife, and I was like, hey, what's really awesome about working out? And she's like, what? She's like, and I responded, when we work out our body, we're working out our spirit. And she said, she rolled her eyes and she's like, that's such a Samism. I do want to give you one example. There's something called Takotsubo cardiomyopathy, also known as broken heart syndrome. This was first described in Japan in 1990 by Dr. Sato. And it was an elderly woman, 80s, 90s, who had, her husband had passed away. And she developed chest pain. And it sounded and was described just like a heart attack. And so they were like, hey, we need to go in and do an angiogram, put in stents, maybe do surgery. But when they went in and did the procedure, they found all of the coronary vessels were clean. But it felt exactly like a heart attack. And so when they did an echocardiogram, they found that the left ventricle had become abnormally shaped. The normal left ventricle is on your left, but then on your right is this abnormal left ventricle. And the reason they call it Takotsubo is because apparently that's the shape of an octopus trap. Because it's this abnormal shape, it's not able to pump effectively. So this is one example. There have been multiple reports of people who have experienced just terrible things or frightening things, or maybe their loved one dying, something in front of them, and they develop this thing called Takotsubo cardiomyopathy, right? So again, that's just that example that when someone experiences something psychological, it can affect the biology, and this is a clear manifestation of that. At Reset Ketamine, we have 4 phases. Preparation, so that's critical. 1 week before the ketamine infusion, we ask them to prepare. We have a list of guidelines. Number 2 is the intention. Why are you doing this? What is your goal? What is your outcome? And number 3, you have the ketamine experience itself. And we want patients to experience the experience, not analyze it, not think about it, but just be with the experience. And then the final phase is integration, which is taking the lessons, the insights that they've gained from ketamine and taking action on it, which might be increasing exercise, which might be eating healthier, which might be going to church, which might be doing yoga, whatever it may be, integrate that experience. Our protocol, we give 40-minute ketamine intravenous infusions. We do a range of 0.5 milligram per kilogram to 1 milligram per kilogram. We do continuous cardiac rhythm monitoring, oxygen saturation monitoring, respiratory rate, blood pressure monitoring throughout the infusion. We recommend 6 infusions that spread over a 2 to 4 week time frame. Some patients need booster infusions, which might occur once a month, once every 2 months, once every 3 months, once every 6 months, depending on how their symptoms are. It is not covered by insurance at this time. I know someone earlier at the prior ketamine presentation had asked about coverage. Yeah, it's not covered by insurance because it's considered off-label use. But to me, this is mind-boggling because ketamine infusions are actually cheaper than what's currently out there. For example, transcranial magnet stimulation, TMS, or ECT, electroconvulsive therapy. Those are like 20 to 30 grand, and insurance does cover it. But why isn't ketamine, which might be 3 grand, 5 grand, why isn't that covered? Look, the biggest reason is it doesn't have FDA approval because it's being used off-label. And to get FDA approval process going on a generic drug, there are no financial incentives for Johnson & Johnson to say, hey, let's take a generic drug that anyone has access to and do randomized control trials, which cost each phase 1, 2, and 3 can cost anywhere from $10 to $20 million. So no one has a financial interest to, again, take ketamine and run it through the FDA approval process for a different indication. So I want to give you some case studies. The first patient, patient A, he's a 55-year-old male. He has treatment-resistant depression. He has tried transcranial magnets. He's tried Wellbutrin. He's tried Prozac. He's done everything, and nothing is working. So we gave him the infusions. On your left, you have the PHQ-9 score, and on your right, you have the Zung anxiety score. He started out at about a 16, 17 on the PHQ-9. The higher the number, the more severe the depression. And then by the end, he was below 5. It was like a 3 on immediately prior to a 6th infusion. And then on his Zung anxiety score, he was like a 33, which is actually within normal range. But then the anxiety levels dropped even further. Some of his quotes, he said, "My depression is simply gone. Now I can mold my life the way I want it. Can't remember when I felt so good. Thank you so much for your help. I feel like I have a future now." Patient B, she's a 43-year-old military veteran who's on a host of medications. She has anxiety, treatment-resistant depression, post-traumatic stress disorder, chronic pain, and her PHQ-9s started at a 21 and dropped to a 15. Her Zung anxiety scores went from like a 51 to about 31, which is the normal range. Her PTSD scores also dropped from 27 to about 21. And she says, "Hey, I'm feeling so good. I had a good session at my doctor's office. She said my numbers haven't looked so good since I started counseling. I was pleased to say the least." And what was cool was that she didn't need as much Percocet and Neurontin for her chronic pain, and she was sleeping better. The last patient, patient C, he's a 49-year-old male. He has a history of depression, social anxiety, and again, if you look at the PHQ-9s and the Zung anxiety score, those have pretty much, almost gone back to normal levels in this patient. And he said, "This is the first time in my adult life that I feel something is changing. I had a great weekend. I also noticed a big improvement in my ability to talk to other people and have a lot more desire to connect. So I'm feeling excited and hopeful." So I want to finish with my conclusions. Ketamine is a legal, safe medicine. It's been used for over 50 years. Ketamine is an MDA receptor antagonist blocking activity of glutamate, which increases BDNF, brain-derived neurotrophic factor. It disrupts the default mode network, which allows for neuroplasticity and synaptogenesis. It can be rapidly effective in treatment-resistant depression, suicidal ideation, anxiety, PTSD. There are limitations. There's no long-term studies. There is an abuse potential, although low, and insurance coverage is limited, and there are some side effects. And number 5, ketamine can play a role in transformation, but it's not a panacea, it's a catalyst. And that's the way I like to think of ketamine. It's, if a person's stuck in quicksand, let's get them out of that quicksand, help them out, but then they need to start walking once they're out of the quicksand. And so ketamine is only one part. We encourage psychotherapy, we encourage exercise, we encourage healthy eating, to really integrate all of their insights. So I want to leave you with this quote. The 2 most important days in your life are the day you're born and the day you find out why. So if you're watching this video, you made it to the end. Congratulations. Thanks for being with me for the entire presentation. Hope you learned a lot and enjoyed and gained something from this 30-minute video. And if you liked it, please subscribe, please give us a like. And of course, if you have any questions, comments, leave it below and I'll be happy to answer them. Until next time.